how do we use ultrasound in daily practice in the life of the ICU? That's another very basic question. That is, how do we do in the real life? On admission, it makes no problem. We scan the patient from the head to the feet. We make a complete evaluation. In the morning, when we have to see our 12 patients, if a patient has no reason of having a concern, if there is no change, it should be maybe hard to make a whole body examination, especially if you are alone with 12 patients, it's sure. The future will be probably the students. They see the patient every day. A student has 3 or 4 patients, so they can make an ultrasound and say to the chair, hey, this patient has something that was not expected. What I do myself in practice is a very fast scanning of the very strategic areas. That is, scanning that the venous network does not develop thrombosis, but not in a comprehensive examination, but in very focused points, 2 points at the 2 anterior lungs. The heart will not move a lot from one day to another, but looking at the pericardial effusion is fast, easy, but one may say not very contributive, because it is highly infrequent that you will develop a pericardial tamponade if you had not an admission. So you can debate very constructively of all these points to define what should be the best strategy for a patient who complains of nothing. And this is a protocol. We just have to give a name to this protocol, one more name, that should make a realistic approach of your patient when you are alone with 12 patients. So I don't repeat, 1 point to the veins, 1 point to the anterior lung, 1 to the posterior lung. The abdomen should be very restricted if there is no complaint. Of course, if there is any desaturation or any fever or any circulatory problem, it is completely different. You scan in the spirit of the whole body ultrasound.